Okay, welcome back everybody, and thanks for joining us for another webinar hosted by Princeton for everyone worldwide. We're very happy to have Amy Finkelstein with us from MIT. Hi, Amy.
Hi, Markus. Thanks for having me.
Thanks. Amy will talk about the healthcare in the United States and about her new book, We Have Got You Covered. The book is co-authored with Unwritten from Stanford, and we're very happy to learn more about the US healthcare system. So before we pass on the mic to Amy, let me just say a few words. First, I would like to come back to an earlier webinar with Agnes Deaton, where he talked about the US life expectancy at the age of 25. And he showed this dramatic decline in life expectancy for Americans without a BA, which is much more dramatic in the United States than anywhere else. If you look at the life expectancy in various other countries, I mean, you see a little bit of a decline, but not so dramatic as it is for the United States, especially for people without a bachelor's degree. And the question is, of course, has health insurance some role to play? And we asked you in the poll questions whether that is one of the reasons. And of course, you could argue that perhaps the difference for the United States is that the United States doesn't have a universal coverage, only a partial coverage. And the question is, if you have a universal coverage, what should be covered in the basic program universally, and what should be a premium coverage? The difference in wait times or doctor choices, and whether there should be some deductibles and some self-financing top-ups. What's the difference between deductibles and self-financing top-ups? And there might be also, I think Amy will argue, there are a lot of coverage uncertainty, that people don't know what's covered and what's not. And in doubt, you don't ask for any special programs. And this, of course, leads to some choice in healthcare that you can choose in the United States a lot, but it also leads to a lot of complexity. And I was wondering, whether this complexity is actually a way to select some adverse selection with regard to how literate or educated people are or not. So this is actually a disadvantage for less well-educated people. And I think that's a big drawback for the US system, and it's a big advantage of a universal coverage system. And whether this, information disadvantage or this complexity disadvantage often is if you give people a choice. Uwe Reinhardt, who is a famous health economist, often compared it with, you don't have any information about the health considerations because it's like walking as a blindfolded in a supermarket, and you give you all this choice. And Ken Arrow made this point earlier on as well with regard to health insurance. Now, let me come back a little bit to Amy's earlier work. I think she will talk less about this today, about insurance economics. Of course, she worked a lot of adverse selection. The question is always typically in a Rothschild-Stiglitz type of world, the consumer has some informational advantage. If you have universal coverage, you don't have this adverse selection problem. But if you do top-ups again, or you do some special treatments, you might have some adverse selection issues again. And, typically, it is the case in these models that the high-risk type is underinsured, while what we see in reality is that the high-risk types typically are fully insured and are more aggressive to get the insurance. And that led, I think, Amy and Liran to this concept of advantageous selection, where you have a two-dimensional type space. One is about the risk, whether the high-risk or low-risk type, and the other one, how risk-averse you are. It's a preference type. And depending on the correlation between the risk type and the preference type, you can actually then resolve this puzzle. I mean, a different approach is also that you say, okay, the whole assumption that the consumer has an information advantage is a little bit outdated in today's age. It is actually much easier for the insurance company to figure out what is actually the risk I have of suffering a heart attack or something. Of course, I know better about my own lifestyle, but the statistical information across different types of information, the insurance company might know much better than I do, in particular in the age of AI and machine learning and other tools. The insurance company might have some information advantage. You can have, an informed principles approach, where the principal essentially has information advantage in one dimension, and the agent has an information advantage in some other dimension, and that actually might resolve this issue. So with this, let me go to the poll question. Thanks a lot for everybody for participating in the poll. So the first question was, let me call it the Agnes Deaton question. Why is the US life expectancy so low, or why did it decline so much? Is it because of US healthcare? That's 25% thought that was the case. Is it because of lifestyle or obesity? 59% thought. pollution, only 2% thought that's an issue, or drug abuse and suicide aspects is 14%. So the majority thought actually it's lifestyle obesity, and the second highest is US healthcare. We will probably get Amy's perspective. I think she knows much about that question. The second question is, one is to say, okay, we have a basic universal coverage, and then we have a top-up for public healthcare. So instead of having your own insurance to replace the official one, you have a top-up. Is this more efficient? That's what 70% thought. Or is it actually a redistribution from the wealthy to the rich? That's what 33% thought. So actually, you could choose both if you wanted to, and some people did. And that's why it doesn't add up to 100%. The third question is, who has information advantage in this insurance market? Does the customer or the patient know best? 21%. The insurance company actually knows better, 45% thought. And doesn't really matter for universal coverage. So you could also pick more than one option. Here was 34%. So with these questions and this whole perspective, I pass on the mic to Amy to learn more about her proposal, how to change the US healthcare system. Thanks again, Amy. Looking forward to your presentation.
Thank you, Markus, very much. Can you see my screen?
Yes, perfect.
Okay, terrific. So, as Markus said, this talk is going to sort of give a high-level overview to a new book that I wrote this summer with my long-term collaborator at Stanford, Unwritten Einav. We are both academic economists. We've worked for over 2 decades at this point, a lot of that work together, studying U.S. health policy and health insurance markets. And, as Markus mentioned, a lot of our work was actually on asymmetric information and adverse selection, and thinking about that as a motivating role for government policy in health insurance markets. This book ended up somewhere very different from that. And in part, just to give you a little intellectual background, neither Laurent or I have been involved in public policy debates, serving in administrations, advising political campaigns. I'd say, at least for myself, a lot of what made me interested in the questions I was working on were those big picture policy questions, but I was more trying to figure out the answer than tell people what the answer was. So why this book? Well, people would often ask us, what do you think should be done about U.S. health insurance policy? And I would tell them the truth, which is I don't know. That's why I study it. I don't study things that I think I know the answer to. And that usually ended the conversation. Perhaps, they didn't like the answer, but they accepted it. As we say in the prologue to the book, when my father-in-law posed this question to me in summer of 2019, he was not going to accept that as an answer. And he came back to me and said something like, come on, Amy, you must be, one of the world experts on this topic. So that's a little bit of hyperbole, but, your family member is allowed to see you through, rose-colored glasses. But he said, are you seriously telling me you've been working on this for 20 years and you have nothing to say about how to better design U.S. health insurance policy? And put that way, it sounded kind of bad. And so this book started with Laurent, my telling this to Laurent. We talk almost every day because we work together so much. And, we were like, yeah, he kind of has a point. We should at least have a framework for thinking about this issue. And I honestly thought at the beginning of this project that we would come up with a framework. It would, outline several competing goals, tensions, trade-offs. And we'd say, it depends on the relative weight or magnitude of A versus B, and that's something we need to do research on. And we'd tell my father-in-law maybe we'd write a short piece in an economics journal, a thought piece, but that was sort of where we thought we'd end up, because that's where almost all of the economics I've worked on has ended up, that there are trade-offs. And what prompted us to want to write this book and reach a much broader audience than my father-in-law is we actually, in the course of thinking about and researching and arguing about this topic, actually thought we have figured out the answer, that there's actually a very clear and compelling argument for what the US should do. It's not rooted in any of the things like adverse selection that we had been working on. And we wanted to try and get that out there to actually influence the broader policy debate. And true to what I said at the beginning, that I don't work on things I think I know the answer to, going forward, I mean, I continue to think health insurance is fascinating. I'm happy to advise students working on it, but I personally want to pivot from thinking about health insurance design, which I at least feel I now have clarity on, to thinking about some of the issues we don't have clarity on, including how to efficiently deliver healthcare and also, how to improve population health, two of the things that Markus mentioned at the beginning. So with that by way of background, let me sort of briefly try and sketch an overview of the book. I should say that the remit Laurent and I set for ourselves is to try to think freed from political constraints. What would an ideal health insurance system look like? We talk at the end and at the end of the book as well on the politics, but I think that's the right place to end, not to begin, because we can't start thinking about what's politically feasible or what political compromises we are or not willing to make unless we actually have a clear vision of where we're trying to get to. We can also hope that maybe the politics may change and maybe this will actually get on the table. It's very hard to predict the future. Okay, so the book has, with that by way of background, 3 parts. The first part describes the problems. I'm going to go through that pretty quickly. The second part does something that I think is natural and obvious to economists, but is rarely done, I think, in a lot of policy discussion, which is describe the objective. Before we start talking about solutions, we have to get clarity on what is it we're trying to accomplish. And there are many potential good reasons for government intervention in health insurance markets. There's the type of market failure issues that Markus mentioned and that we had worked on for most of our careers. There's using health insurance as a form of redistribution. There's trying to improve population health. All of these are things that people have worked and written on, including ourselves. What kind of struck us when we thought about it from the perspective of this book is we don't actually think any of those are the problem that has been motivating US health policy for the last 50 to 70 years. So I'm going to articulate what we think is the problem that is motivating government policy. And if we can convince you of that, then I think the solution becomes startlingly clear and simple. And as I said, that was why we wanted to write the book. So let me just start briefly with the problems. I'm not going to spend too long on this because I don't think there are many people who think the US health insurance system is working well, but I want to just cover 3 main problems. The first, which is I think the one that gets the most attention is that, we are the only high-income country without universal health insurance, which means that 1 in 10 Americans under 65 at a point in time lack coverage. But if that was the only problem, I think the solution, at least conceptually, would be a lot simpler. There are 2 other problems I want to highlight, and these affect not just the 1 in 10 Americans under 65 who are in the unfortunate position of lacking health insurance at a moment in time, but they actually affect the remaining 90% of Americans who are fortunate enough to have health insurance at any moment. And the first of those 2 problems is what we call insurance uncertainty. So the fact that, yes, 1 in 10 Americans under 65 at this very moment are uninsured, but we estimate that more than twice that number, 1 in 4 Americans under 65, will spend some period of time without insurance over a 2-year period. And conditional on losing their coverage, they're not going to be uninsured for a few days or weeks. Half of them will be uninsured for 6 months or longer. A quarter of them will be uninsured for 2 years or longer. And the other thing we find that's quite striking is that while, as many people may know, the 2010 Affordable Care Act, popularly known as Obamacare, really reduced the fraction of people uninsured at a point in time from about 1 in 5 to 1 in 10, it barely moved the needle on the share of people who will lose coverage over a 2-year period. And the reason for that is that it continued the sort of incremental patchwork approach to US health policy that we've been pursuing for decades, expanding Medicaid, setting up marketplaces. The challenge with all of these different pathways to eligibility is that whenever you have different ways of qualifying for health insurance, there always are going to be people who don't realize, who either aren't eligible, they miss, one of those paths because there's like a gap at the seams, or they don't realize which pathway they're eligible for, or they aren't able to file the requisite documentation to demonstrate their eligibility, or they do, but then because every program is specific and depends on your income and your age and your health status, periodically the government needs to check that you're still eligible, and as a result, people fail to recertify and can lose their coverage. So this is the type of complexity that Markus was alluding to in the beginning. It applies not just to people with public health insurance, the Medicaid program that was dramatically expanded under Obamacare, but also to the half of Americans who have private health insurance through an employer. They can lose their coverage if they change jobs, retire, or lose their job, perhaps because of a medical issue. So at a high level, if, as economists, we all think of the purpose of health insurance as not to insure your health. It's a bit of a misnomer as a term, but rather to provide some measure of economic security, right? To allow you to smooth consumption or marginal utility of consumption across states of the world. So it's highly perverse that insurance itself, that is supposed to be a stabilizer, is itself, in fact, highly uncertain and insecure. And then the final problem I just want to highlight is that even for people who are fortunate enough to have health insurance and to maintain that health insurance when they fall ill, that health insurance is often highly, highly incomplete by design. So, for example, Medicare, the public health insurance program for the elderly and the disabled in the United States, which covers about 1 in 5 Americans, deliberately builds in consumer cost sharing, the need for consumers to pay some portion of their covered care. For physicians, patients have to pay 20%, 1 in 5 of dollars for medical bills, and that's uncapped. There's no limit. So that if, in fact, you unfortunately are quite ill and have very high physician bills, for example, through an oncologist, you can end up having to pay tens of thousands of dollars or more for your supposedly covered care, which again is not how health insurance is supposed to function. It's supposed to provide protection, and especially catastrophic protection. And so a really startling fact that crystallized this for us is work that other economists have done, has previously done, had documented the enormous amount of medical debt held by collection agencies in the United States. They estimated that prior to the pandemic, the amount of medical debt held by collection agencies was as large as all of the other consumer debt for non-medical sources held by collection agencies, so truly enormous. But I think I had always just assumed that that was because of people who were uninsured. In fact, we estimate that 3/5 of that medical debt is incurred by individuals who had health insurance at the time that they incurred their medical expenses. But because of, the trend towards high deductible employer health insurance plans, $3,000 to $4,000 deductibles, these other types of cost sharing that I talked about, you can still face a lot of risk.
So, Amy, can you say a little bit, if we didn't have this deductible and this co-payments, how much more would the Medicare then have to pay, in a sense? Do you have a calculated billions? Because the incentives are changing too. Is the incentive structure a big issue that, you go to the doctor more frequently if you don't have
Yes, and I will this is a great question, and I will definitely get to it. There is an enormous empirical literature, some of which we have contributed to, documenting incontrovertibly that when people have to pay something for their medical care, they use less of it. And this has caused, a generation of economists, myself included, to preach the virtues of, some cost sharing in health insurance so that individuals, face some, financial skin in the game, make judicious choices in their medical care. And in the course of this book, we say unequivocally, we take that back, at least in the context of the type of universal basic system that we are proposing for supplemental coverage. That's all fine. The reason why, though, actually relates to the question of what are we trying to accomplish? So if you'll give me 15 minutes or so, I'll definitely come back to it. Let me, in that regard, just go very quickly and say, we talk in the book about why we don't think incremental reform will work, and we talk about the history of many health insurance policies that have come about. In the interest of time, I'm not going to dwell on that in detail. I just want to say that doing this makes several points. At first, it shows the futility of these, purely incremental approaches, because they always leave unanticipated gaps at the seams, as well as complexity. So a very startling fact I find is that of the people who are currently uninsured at a moment in time, 6 in 10 of them are already eligible for either free or heavily, heavily subsidized health insurance. And there's a lot of evidence to suggest that they're not on it, in part because they don't know which program they're eligible for, how to qualify, and this type of patchwork is part of that problem. The other reason we spend a lot of time on this patchwork is it gives us our first hint at what we think health insurance policy is actually trying to do or has been trying to do in the US. All of the examples on the screen, not that I'm telling you anything about them, and many more in the book that we describe, all have the feature of some issue gains political salience and popular attention, people dying of end-stage renal disease because they can't afford coverage, disabled children who can't go home because they'll lose their health insurance coverage. They can only qualify for Medicaid if they're not with their parents. People suffering from Lou Gehrig's disease and having to wait, which is a fatal condition often in a year or so, but having to wait 2 years to qualify for health insurance because of waiting periods. The list goes on and on. These examples, this outcry of people not being able to access essential medical care has in many, not all instances, prompted, limited political action to try and address that particular feature. And to us, in addition to the limitations of this patchwork approach, it also illustrates what we think US health policy has been trying but failing to accomplish for the better part of 7 decades, which is access to essential medical care regardless of resources. And so we spend the entire second part of the book trying to make this claim. We thought it was a hard claim to establish, given that we are famously the only high-income country without universal health insurance. And, we have a tradition of individualism, pull yourself up by your bootstraps. So we spend a lot of time talking about our history, and our current policy, and why we think this social contract exists. I want to be clear, not a normative argument about whether we should have that as a contract, but just empirically, this is what we do. Somewhat to my surprise, I will say that we've gotten essentially zero pushback on that. We've talked to conservatives, to liberals. No one sort of questions that we have this contract. They just question what the solution is. So I'm going to spend a little less time describing it, but I do want to give 2 examples because it leads directly to what the solution as we see it is. And these examples come both from our distant past and from the present. So from our distant past, if you go back to the early 19th century and the development of hospitals in the United States, there's a wonderful book by Charles Rosenberg, who's a historian of medicine, describing the origins of hospitals. And as he explains it, hospitals arose in the United States primarily as charitable institutions, not medical institutions, right? This is the early 19th century, at a time when, the germ theory of disease wasn't around, medical care could do very little, and the standard of care was really just nursing comfort by one's family members. And so then why did hospitals arise? Well, in the newly forming cities, typically in port towns, people were often now no longer surrounded by their extended family and in more crowded spaces where they didn't, family couldn't tend to them. And so as philanthropic charities, hospitals sprang up because, as Rosenberg says in his book, fellow creatures could not be allowed to die in the streets. And that impulse, and we talk about some of the psychological origins of it in the book, that impulse that we can't stand idly by when someone is suffering from a health or medical problem and can't get the care that we think is essential, has permeated all those health policies that I flashed up, and currently our current policy. So one sort of provocative claim we make in the book, or maybe I should say counterintuitive in a book about health insurance reform, is we point out that no one is actually uninsured in the United States. So what do I mean by that? Well, what would it mean to be actually uninsured? It would mean that any medical care you got, you paid for. But, drawing on work that I and others have done from the Oregon Health Insurance Experiment, which was a randomized experiment in which some low-income adults were randomly assigned Medicaid coverage, public health insurance for low-income individuals, and others remained uninsured. we can see what happens. So first, to Markus's point about moral hazard, absolutely. When you give people formal coverage, they use more medical care. In fact, we estimate that medical care goes up by 25%, and that's across the board. That's not just the emergency room, that's primary care, preventive care, hospital care, prescription drugs. But if you just turn that number on its head, 1 over 1.25, another way of saying that same fact is that the uninsured are receiving 80% of the medical care that they would receive if they were insured. And crucially, what we estimate, and others have made similar estimates, is they're only paying for 20% of the cost of that care themselves. So where's the other 80% coming from? Well, it's no longer, philanthropic efforts. This is not, GoFundMe campaigns. The vast majority of that 80% is paid for through public programs, publicly regulated, publicly funded programs designed to provide community health centers for primary care, public hospitals to fund hospital care, tax subsidies to nonprofit hospitals to provide charity care. We don't think it's working well, as we've already talked about, but it's these tangled set of programs and public commitments and public requirements and public funding, we think are the modern day illustration that essentially we are committed to trying, when people are sufficiently ill and unable to afford the care they need, to trying to step in and provide that care. And if we have convinced you or can convince you, or you are already convinced that we have that social contract, that's where we say the skies sort of part and the solution becomes extremely simple. It's something that's been recognized and embraced by people across the political spectrum. It's not an old idea. It actually goes back to the very dawn of our republic. So if you want to take one just really fun fact away from this talk, there was actually a time when the US, rather than being a laggard on health policy, was actually a leader. We introduced the world's first compulsory tax-financed health insurance, and we did that in 1798. And I think this reveals this fundamental social contract even back then. It was an act for the relief of sick and disabled seamen, a federal law that specified a tax on sailors when they arrived at port, and these are commercial sailors, 6 cents per sailor per month at sea, to be deducted from their wages, handed over to the customs agent, and used to finance local hospitals. Why? Because seamen would come to port ill from their journey. They come from all over the country, but they then fall ill in these few port cities, Boston, Philadelphia, New York, and they became a real burden on those communities. It's not coincidence that that's where the first set of hospitals developed. It's precisely the type of people who no longer had access to family care. And as Alexander Hamilton, when he was Treasury Secretary, you all know him very well, of course, when he was arguing for this legislation, he said the interests of humanity are concerned in it, from its tendency to protect from want and misery a very useful and a very needy class of the community. In other words, given that we are inevitably going to feel bound to step in when people are sick and have no other access to resources, they're alone in a strange city, they can't be left to die in the streets, we might as well recognize we're going to do this, formalize that commitment, and fund it up front through taxing all the sailors in this case, and then having that money pay for the care of some. And that idea, oh, sorry, go ahead, Markus.
Can I draw an analogy, perhaps? I just want to play devil's advocate a little bit. There's nevertheless, you might want to leave some strategic ambiguity. So if I transfer it to some other policy measures, it's like bailing out banks. We might always have an incentive to bail out exposed banks, and we might always do it to 80%. But we don't want to formalize it. We want to keep it uncertain. Otherwise, the moral hazard will be even worse. Would you say in health is different from bailing out banks?
Yes and no. It's different in the sense that, yes, there will be moral hazard, but I think the difference is we ultimately do step in and spend the public funding for healthcare. That's what those past examples were showing. We don't always bail out banks. Well, they have to be big enough, and And so, yes, there is moral hazard. I think an even bigger concern is, well, maybe if we didn't bail people out, then everyone would have insurance, right? Is another, not just like, well, if we formalize it, they'll use more care. Maybe, but I think that's not a viable counterfactual, because as we argue extensively in the book, all of our history, all of the sort of psychological underpinnings indicate that we are incapable of, committing, right? You can, it's James Buchanan called it the Samaritan's dilemma. Whether you think this is a noble feature of our nature or a terrible problem with time and consistency, we can argue about, but empirically, we are not able to deny people care when they're sufficiently ill and unable to afford it. And so therefore, we'll get to the moral hazard component on the health insurance itself. But I think for that reason, there's a broad array of support across the political spectrum. Obviously, progressives like former Supreme Court Justice Ruth Bader Ginsburg, in upholding the constitutionality of the Affordable Care Act health insurance mandate, referred to the healthcare is different from broccoli, because if people don't have health insurance, we're going to feel compelled to do something, step in with taxpayer finance dollars. That was Republican Governor Mitt Romney when he was governor of Massachusetts. That was his argument for the universal coverage in Massachusetts that predated the Affordable Care Act, that taxpayer dollars were going to be spent when people were sick and didn't have health insurance, so we might as well raise it through taxes. It's also something that libertarians have embraced. So Charles Murray, who, a famous libertarian who has argued for completely dismantling the, welfare state and social insurance, giving everyone back their cash. So he argues for a universal basic income of $13,000 a year, funded on the premise of get the government out of people's lives, give the taxpayer back their hard-earned money so they can do what they want with it. Even he makes one and only one exception to that approach, and that's that he's going to claw back $3,000 of his $13,000 universal basic income and use it for compulsory health insurance. Why? Because he, like all these others, recognizes that even if you've given people what we consider sufficient income, if they spend it on things that don't include their health insurance, and then they become sick and need medical care, we are not going to be able as a society, as individuals, and as taxpayers to stand by and just say, well, that was your poor decision making. You have to live with the consequences.
A different argument would be that actually people go too late to the doctor. No, it's not that they're overspent and there's moral hazard goes in that direction, but it could also be that they don't go early enough. And
yeah, so I think the empirical evidence is clear that there is both overuse and underuse in medical care, and then that health insurance certainly contributes to both. There is a popular line of argument that argues for, more expansive health insurance coverage on the grounds that actually it could save money, right? You get people in earlier to primary or preventive care. We had a lot of internal disagreements about that in writing this book. Where we ended up, where I think we were both comfortable, is there's no really compelling evidence for that argument, except with the two exceptions of childhood immunizations and the influenza vaccine. It's also not but that doesn't mean the absence of evidence is not evidence of absence. It's also not a really well posed question or statement, in the sense of, if people get adequate primary and preventive care, they may live longer and therefore they may spend more. And I'm not sure that's a problem. In the end of the day, I'm not comfortable enough with given the paucity of evidence to claim that that's a reason to have health insurance coverage. But I don't think, I think there are we have enough reasons without that. And certainly, I think the evidence suggests that health insurance is a blunt instrument. It encourages use of care across the board, both stuff that we think is underused and high value, like primary and preventive care, and stuff we think may be overused and low value. All right. So the last thing I want to say before getting to the solution relates, in fact, to the question that Markus posed at the beginning about what are the drivers of poor health and health disparities in the United States, because we thought it was, and we spent a chapter on this in the book because we thought it was very important to be clear, not just what is the goal of health insurance, which we at least feel, or government intervention in health insurance, which is to make sure that everyone has access to essential medical care regardless of resources, but also to be clear and humble about what health insurance policy will not do. So it's, it is a important policy lever, but it is not the solution to all our problems. And as anticipated, I think, by the majority of the respondents, we argue in the book that if you are, rightly concerned about the poor levels of health in the United States, that was that Deaton graph that Markus put up in the beginning, or the shocking and disturbing disparities that exist in health across the income distribution and across racial groups, that there are certainly public policies that may be effective in ameliorating those issues, but they are not health insurance policy. Health insurance policy is the wrong lever to lean on. Part of the reason for that, by the way, is not because medical care, which is what health insurance gets you access to, is unimportant for health. Of course, it's incredibly important for health, and it would be silly to argue otherwise, but rather the fact that no one is actually literally uninsured. We don't let people die in the streets. And therefore, while it is true there have been some terrific empirical studies showing that health insurance improves health, the magnitude of that is just tiny relative to the vast health disparities that exist across income groups or between the US and other countries. And this is an old idea going back to Vic Fuchs's book, Who Shall Live, published in 1974, where he talked about the very different health outcomes in two demographically similar states, Nevada having much worse health outcomes and also having, much higher rates of smoking, of drinking, etc. It's an idea that Raj Chetty and co-authors have documented more comprehensively more recently, but and it goes often by the name the social determinants of health. That in addition to medical care, what's really important for health is the air we breathe, the violence we are or not exposed to, the cigarettes we do or do not consume, our diet, our exercise, etc. And I think if I wanted to just give you, one idea to hold in your mind, that what was most compelling to me in this whole body of evidence is work that researchers have done looking at health inequality across the income distribution in countries like Sweden and Norway. Those countries not only have universal health insurance, but they have a much more extensive cradle to the grave social safety network than we do in the United States. And yet their researchers have documented differences in life expectancy between the top and the bottom of the income distribution that are as large in Sweden as they are in the United States. And, when people start to dig into it, things like information and access to medical expertise seem to be important drivers. So I want to be clear, we're solving what I think is a very important problem with health insurance reform as we're proposing it, but we are not solving all problems in health and healthcare.
So you're working next on these other problems?
That's the hope. I'd say that the other thing that we're going to deliberately steer clear of is the problem of healthcare delivery. In other words, the fact that we spend twice as much, the US spends twice as much as a share of the economy on healthcare as any other high-income country and does not experience particularly good health outcomes. There's a lot of consensus that there's a lot of waste and abuse in the healthcare system. But, as the saying about advertising goes, everyone agrees that, 50% of advertising dollars are wasted. We just don't know which half. I think there's a lot of truth to that in healthcare delivery. And so we would like to find solutions to those problems. That and the health are probably what we're going to work on next. But fortunately, what we decided or discovered in writing this book is that it's possible to solve the health insurance coverage problem without solving those other problems. Now, of course, it would be cheaper if we also solve those other problems, but as I'll explain at the end of the solution, you could actually get to what we're proposing without raising taxes, even with current healthcare spending levels. So let me describe the proposal very in a nutshell. It can fit on a single slide. We'll get it eventually to a bumper sticker. It has two components. The first is universal coverage that's automatic, free, and basic. And the second, going to one of the other questions Markus asked in the beginning, is the option for people who want and can afford it to supplement in a well-designed, well-functioning market, which is the part of the book where we actually grapple with the types of adverse selection issues Markus was talking about at the beginning. But I want to actually focus and then open it up for more discussion on the three elements of the basic coverage that I think are particularly important: the automatic, the free, and basic. The automatic, I think, is the easiest. If you agree that we have this social contract to try to provide access to essential medical care to everyone, regardless of resources, then the only way to fulfill it is to do it automatically. We've discovered in the course of the 2010 Affordable Care Act that enacting universal coverage doesn't make it so. We mandated that everyone get coverage. Everyone did not. And so in the same way that the way almost everyone has health insurance who are 65 and over for hospitals and physicians, because Medicare provides that essentially automatically starting at age 65, we need to do that with the basic coverage as well. The other
this would include illegal immigrants as well?
Yes,
Okay.
yes. The other two components, free and basic, I think are more controversial. So let me talk a little bit about them, starting with free. And this gets to, Markus, your question about moral hazard. So just for a bit of intellectual history, there was a time in the early 1970s when Republican President Richard Nixon and Democratic Senator Ted Kennedy had competing proposals for universal coverage on the floor of the US Congress. Just bracket that for those of you who say, this is politically infeasible. We almost got there. We talk in the book about, the politics that happened. One of the central disagreements between these two competing proposals was precisely over this question of cost sharing, with Nixon and the Republican administration arguing that we should have some copays and deductibles so that people would have some kind of financial skin in the game and not just run to the doctor every time they sneezed. Ted Kennedy and the Democrats and the labor unions said this is crazy. Healthcare isn't like other goods. It's not even a good. Nobody wants to go to the doctor. Nobody's going to go get a couple of extra colonoscopies because they're on sale. You go get medical care only if you need it, and if you need it, you'll get it regardless of the price. And therefore, we should not have any cost sharing. This was the subject of much debate. It prompted the government to fund the Rand health insurance experiment, one of the largest social experiments ever, in which researchers randomly assigned people to different health insurance plans with different cost sharing and looked to see what happened. It's prompted decades of subsequent work by economists using quasi-experimental methods, using other experiments like the Oregon health insurance experiment that I mentioned before, all of which have demonstrated incontrovertibly that Nixon was right, Kennedy was wrong. When you have to pay something for your health care, you use less of it. And as I mentioned before, in response to Markus's comment, that has led generations of economists, myself included, to preach the virtues of some minimal cost sharing in health insurance plans. And as I said, in this book, we say unequivocally, we take that back, at least in the context of our universal basic coverage. Why do we take it back? Not because the research was wrong. We stand by the evidence, ours and that of many other economists, that when people have to pay something for their medical care, they use less of it. But because the implications we drew from it were wrong. And the way we know that is when we see what has happened in countries around the world that have followed the advice of economists, and when faced with budgetary pressure, have introduced cost sharing into their universal basic coverage plans. And what you see amazingly in country after country, France, England, Germany, many other countries, is that it's almost simultaneous. They introduce the cost sharing to try and rein in costs, and then they introduce the exceptions and the exemptions, right? So for example, in the UK, where they introduced originally in the National Health Service, all medical care was free at the point of service. Faced with budgetary pressures, they introduced cost sharing for vision, dental, prescription drugs, and then came the exemptions. So who's exempt from prescription drug coverage? If you're old, if you're young, if you're poor, if you have cancer, if you're a student, if you're a veteran, the list goes on, so that at the end of the day, 90% of prescriptions in the UK are dispensed to people exempted from the cost sharing. Similar thing in France, where they actually have quite high cost sharing, sometimes as much as 30% for certain procedures and lab tests. The government pays to cover that cost sharing for low-income individuals, and then it offers extensive tax subsidies to encourage individuals to purchase and employers to offer coverage of those cost sharing for the rest of the income distribution. The end result is that 95% of people in France have coverage for the cost sharing. So, and you see the same thing, by the way, in the US with Medicare, the public health insurance program for the elderly. 95% of people have typically tax financed coverage for the cost sharing. So Markus, the answer is we're against cost sharing in the basic plan. We want everything completely free, not because medical care isn't responsive to price, but that it's not responsive when you don't face those prices. And the reason you get all these exemptions, and the reason I wanted to defer answering the question till now, is precisely the reason we have universal basic coverage in the first place, which is if there's a commitment that there's certain essential medical care that everyone should access, there are always going to be people who cannot afford even a $20 copay for a doctor visit or a $5 copay for a prescription drug. And that's how we end up creating this patchwork of exemptions and exceptions, the same type of complexity that we have in the US health insurance system, just with the microcosm of cost sharing.
But you would argue that the healthcare, like many people would like to know how this compared to other countries, is much less complex in other countries compared to the United States.
The health insurance is less complicated. The exemptions are very complicated. So trying to figure out how you're eligible, whether you're eligible to have your prescription drug copays waived, and what you have to do to demonstrate that eligibility and what you have to do to retain that eligibility is exactly the same, all the same fixed costs that one has to go through in the US to get health insurance coverage writ large.
But let me be a little bit cynical. I could say I do this cost sharing and have an exemption. So if somebody attacks me as a politician, I can say, we have this exemption there, but I know most people won't take up on it because it's too complex.
But they do. That's what I'm saying.
So good that I have the exemption.
Yeah. But in fact, if people weren't taking up on it, then it might do something to rein in costs. In fact, as I said, 95% of people in France do have coverage for it, in part because the government automatically provides it if you're sufficiently low income, again, in recognition of the fundamental social contract, and then higher income people, they tax subsidize them to have it. So
the take-up rate is very high on these exemptions.
Yeah, although again, take-up might not be exactly the right word, because a lot of it is done automatically by the government. So same in the US, if you're an elderly person on Medicare with this high cost sharing, if you're sufficiently low income, the government will say we're covering that. But then, of course, you get to the question of, well, fine, it's fun to get up here and say automatic, free, at what point does reality hit in, right? We are economists after all. And that's what gets to the third key element, which is basic. And this is something that we're very clear on the book. And again, we feel comfortable doing this because our social contract, as we try to articulate, is about ensuring access to essential medical care for everyone. It's not about ensuring a high-end experience. And so what we're arguing for is what many, many other countries do. We talk a lot about the examples of Australia and Singapore, where what the basic coverage gets you is essential medical care, but not a high-end experience on 3 dimensions that I'll discuss. And then you can buy additional health insurance if you want to supplement and get additional care. So the 3 main dimensions, the first, which we're showing up here, is there's a lot of non-medical amenities that come with healthcare. A classic example is a hospital room. In Singapore, the basic coverage will get you access to hospital care with 10 people to a room. In a climate that's hot and humid, they euphemistically refer to these rooms as having natural ventilation. If you buy the supplemental coverage, the highest end version of that will get you a private room with air conditioning, with a private bath, with high-speed internet, with good food, etc. those are all nice to have, but to us, that is not part of the social contract. We're trying to provide essential medical care, not a luxurious experience. And we give the analogy in the book to budget airfare. Anyone who's taken one of these budget airlines that have taken off across Europe, probably understands that, these are not great experiences. We'd all prefer more legroom, unlimited unchecked bags, free high-speed internet. But if the social contract was that to deliver you by plane from point A to point B, they do that. And people who want a better experience can upgrade to business class or a different airline. The second dimension, other than non-medical amenities, is wait times. Wait times for non-urgent care under our basic plan would be longer than they currently are under private health insurance or Medicare. They'd be more like the longer wait times that exist under Medicaid in the United States, or that people in the covered by the Veterans Administration health program for veterans in the United States experience. So you can think of our plan as closer to Medicaid for all, but with the option to supplement, than Medicare for all. And we actually estimate that because of that, about 70% of the population would buy supplemental coverage. So the currently uninsured are better off with our basic plan. People who are currently on Medicaid are also better off with the basic plan because the basic plan is essentially Medicaid, but now no risk of losing it if your income changes or your disease status changes or your age changes. People with private health insurance and Medicare will find some benefits to the basic plan, namely no uncertainty, no risk of losing their coverage, and no risk of having to pay out of pocket a large amount for anything that it covers. But I want to be clear, on most other dimensions, it would be much more basic. Few non-medical amenities, longer wait times for non-urgent care, less choice in which doctor you see if you're currently in Medicare, more, intervention in terms of, prior authorization, needing a referral, et cetera, which a lot of people already have now in private insurance. And so at the end of the day, we expect that they would supplement. But again, they can supplement through a top-up mechanism where, you can think of the basic care as it's automatically provided, but if you opt out of it, you get a voucher equal to your expected costs that can be, as long as you take it to buy coverage that covers everything the basic would cover and then some additional. So you're just paying on the margin for the additional coverage.
Can I ask you two questions? One is, what's basic or non-basic is part of a social contract at the moment, what's this implicit guarantee from the social contract, but that the social contract is very fluid. It moves over time. So it is also like what's a human right and what not is, having an internet connection, it seems to be a human right, but 20 years ago, it was not. Once you write it down, do you, freeze it essentially? What's basic and not basic? Becomes less fluid in a sense.
I love this question because usually the same question is phrased a different way. It's saying, but all of this depends on like what you said, what is in basic, and you haven't defined basic. And our answer is, we don't define basic except at a very high and obvious level, precisely because, as you say, this is not a one and done type decision. The notion of what is essential medical care will change as medical technology changes, as incomes evolve, and as what are notions of what constitute disease change. And so what we say is we need to do what every other country does, which is, first set a budget. Let me just be clear, that's something the US government does not currently have when it comes to healthcare. When we talk about, say, the Medicare budget, we mean how much Medicare spent last year or how much we're projecting it will spend next year. We don't mean an actual budget constraint that, school districts face for education spending or transportation departments face for infrastructure. And once you set a budget, then we need to decide, which new technologies or new procedures to cover. And the way this gets done in most countries is a two-step process. In the first step, there's a sort of series of technocratic reviews in which physicians and economists largely will score different technologies on their cost effectiveness. How much health in some metric are we getting per dollar spent? And then in the second stage, a group of stakeholders, politicians, other representatives will look at that cost effectiveness and use it as one input among many into making decisions of, where the priorities of need are. Some places like the UK famously prioritize cost effectiveness more, but even they make exceptions. They set a higher threshold for cancer drugs than for other things. Others, use it less. And that's what we have to do. And in some countries, it's done regularly every year, and others every 3 to 5. But yes, that's an unavoidable component of it.
So the second question I have about the top up. So right now, if I can have some basic treatment, let's suppose I'm older than 65 or whatever the cutoff is for Medicaid, then I can get the basics. But if I want some special treatment, I have to not only pay the marginal treatment, I have to pay everything. But once I can only get the preferential treatment or the premium service by paying only the top up, the marginal costs, there will be a hole in the budget in a sense, or at least I have to pay less than compared to the current setting.
Yes. So just to unpack what you're saying, consider, for example, in the UK, which does not have a top-up system. So if you want to supplement, you have to purchase everything in the supplemental market, including what the NHS would have paid for. So, the NHS will cover cataract surgery with a basic lens. If you want cataract surgery with a high-end lens, you don't just pay the incremental cost between the basic lens and the high-end lens. You leave the system entirely and have to pay for the surgeon, the basic lens, and the incremental cost, right? And we're proposing, no, you just pay for the incremental cost. It is certainly the case that government spending is going to be higher under that plan, but we also think that's the way you get like an efficient. You don't have just pose an enormous tax on people who want something beyond the basic.
But the wealthy will gain from that. No? The people who go for the preferential treatment.
So yes, the 70% of the country we're estimating will get supplemental will benefit. I guess. And I'll get to the budget in a second, but I guess to be a rather boring traditional economist, my view is to the extent we are concerned about income and wealth inequality, we should deal with that through the income and wealth tax system, and we shouldn't distort choices in any particular market. But I do think the budget is the last thing that's really critical to talk about. So I want to at least briefly mention that. As I said, we all know that the U.S. Spends an enormous amount on healthcare as a share of GDP, twice as much as any other high-income country, about 18% of GDP. And there are all kinds of concerns that the U.S. healthcare system is in crisis. This is Vic Fuchs, who's considered the grandfather of health economics, making this statement. But I want to point out that he made this statement in 1974 when the US was spending 6% of GDP on healthcare instead of 18%. So we've been in crisis for a long time, and the sky's been falling. In the book, when we say relax, we can afford it, that's not because we don't think there are these real problems of waste and abuse. But we don't know how to solve those, or how to solve them at scale. What we do know is that we could get to our universal basic coverage program without raising taxes. And the reason is very simple. We all know the US spends twice as much of the economy on healthcare as a share of GDP than other countries. But also just remember that in most of those other countries, the 9% of GDP being spent on healthcare is essentially all taxpayer financed. Whereas in the US, only half of it is taxpayer financed. So 9% of GDP is being spent in the US on taxpayer financed healthcare, and 9% is being spent by out of private dollars. So in other words, our tax dollars are already paying for universal coverage. We're spending 9% of GDP on taxpayer financed healthcare, which is what other countries spend on universal coverage. We're just not getting it because we've chosen to allocate those tax dollars to a more expansive program for the elderly, the 65 and older, one that has no budget constraint, that will cover any medical technology under the sun that's deemed effective. They're not by law allowed to take cost into account in making coverage decisions in Medicare, and has left the rest exposed to a patchwork set of programs that are not fulfilling the social contract. So we could also choose to raise taxes and do something better than basic, but we wouldn't, and that's a political decision, but we wouldn't have to get to where we want to go.
So let me get your expertise on this. One argument is that the US is spending so much because the medical innovation, the rest is done mostly in the United States. And this is very expensive. And the US essentially is subsidizing the rest of the world, because in other countries, there's some government agency controlling the drug prices and all this. And we have this much less in the United States, but essentially that's why innovation happens here. And then it spills over to the rest of the world. And that's a huge gift we are giving to the rest of the world. Would you agree with that, or would you cut back on these gifts? Or
I've always wanted to write a paper looking into this question, absent my or someone else's ability to do that. Yes, there's a lot of evidence, some of which I've produced, much of which others have produced, that, as would surprise no economist, innovation does respond to expected profits. And to the extent that we think that a lot of those profits are in the US versus other countries, I do think we are probably subsidizing innovation for the rest of the world. Whether that's a good thing or a bad thing depends both on what you think the marginal value of the innovation is relative to the cost, and to what extent your social welfare function includes people in other countries. I mean, mine does, but people differ. I guess what I would say about this, which you can view as a feature or a bug, it's a feature if you want to make sure innovation continues. It's a bug if you want to reduce healthcare spending, is that nothing in our proposal is going to has to change anything about the level of healthcare spending or the way care is organized and delivered. There are people who think we should change those, and you could add that. But just to be clear, I haven't said we're going to reduce healthcare spending. I've just said we're going to take the taxpayer dollars and use them differently. And then, if everyone supplemented, or 70% of people supplemented, we might be back at 18% of GDP easily. It's really just a question of, are we going to subsidize, fairly comprehensive health insurance for the elderly, or are we going to provide a more bare bones set of essential care for everyone? So I don't think it has to. It would have to do anything with innovation.
And in terms of paying for the basic service, or the something, would you still tie it to a job or the wage income?
So there's two ways to answer that. One is for the people we've talked to about this plan who say, quote, it will be too disruptive. We can't, we can respond truthfully. No, it doesn't have to be disruptive. There's no reason that you couldn't take your voucher for the basic plan if you wanted to supplement and use it towards purchasing an insurance product that's provided through an employer. That being said, one of the major sources of taxpayer-financed healthcare is the money spent on the tax exclusion for employer-provided health insurance. The fact that in the US, if your employer pays you wages, you have to pay tax on them, but if your employer contributes to your health insurance premiums, you don't pay tax on that. And personally, and I think most economists think that that's an incredibly inefficient system. Uwe Reinhardt said, if we had to design this from scratch, nobody in their right mind would tie health insurance to employment. It distorts labor market decisions. It's an incredibly regressive tax because higher income individuals have higher marginal tax rates and tend to be in jobs that offer health insurance. And in work that I've recently done with Casey McQuillan, Owen Zadar, and Eric Zwick, we also find that it sort of imposes a tax on low-skilled workers relative to high-skilled workers, because low-skilled health premiums are kind of fixed, but they're a higher share of the earnings of lower educated workers than higher educated workers. So personally, if or when I'm made czar of the country, I would not tie health insurance to an employer. I agree with Reinhardt. But if those people who are going to actually do the hard work of getting to this, as a policy solution, think that they want to minimize disruption, they could keep it tied to employers.
But do you know of a number of efficiency loss because it's tied to the wages, that people don't switch jobs and there's some,
Yes,
Has anybody estimated this efficiency?
People have estimated, yes, I don't know that anyone's done a full-blown welfare calculation of all the three elements I mentioned. There's been estimates of the amount of job lock. The estimates we did on the sort of tax on lower educated workers suggested that, and this was a sort of calibration rather than an estimate, but we calibrated that sort of the increase in labor market inequality attributed to this flat head tax on, workers is as large as the sort of role of other things that have been shown to be increasing inequality, like the decline of labor unions, or the growth of industrial robots, or increased trade. So it's quantitatively important. The exact magnitudes, I'm sure we can all quibble over.
Can you ask questions, or
I'm basically done. I can talk about the politics, I can talk about the supplemental, but I'd be delighted to hear people's thoughts and questions.
Yeah. So let me just go perhaps a little bit beyond that. So when you look at CBO projections about healthcare expenditures, it was actually way more pessimistic. So they expected the inflation coming from healthcare to be much higher than actually it is turned out in the last 5 or 10 years. Going forward, we expect actually that the health expenditures are not rising the same degree they were rising the last 30 years.
So you're not going to trick me into making a forecast. I'm not a macroeconomist and I'm not a forecaster, but I will say, apropos of my earlier comment, that I'm turning my energies away from health insurance, which I think is now a very important policy problem, but no longer as much of an intellectual puzzle for me, towards issues of producing health and producing healthcare efficiency. I am very intrigued by this finding. Just to be clear, the slowdown in the growth of healthcare spending, which has been extraordinary over the last 10 to 15 years, is in publicly financed Medicare spending. So private or commercial spending has not slowed down, and there's some question of, are we just shifting? There is some evidence that some non-trivial portion of that slowdown is just a mechanical function of payment reform that reduced payments and payment growth, but there's another large chunk of it that we don't understand, and that I'm actually now working with some colleagues to try to understand. I will say, because I won't be able to say it in print because we'll never have any evidence for it, that one thing that I find just striking is that there are only 2 time periods in post-war US history where we've seen this type of slowdown in healthcare spending growth. One started around 2010, around the time of or 2009, around the time of the debates and then enactment of the Affordable Care Act. And the other started around 1994, just as the Clinton proposal for universal health coverage was falling apart. So I have some gut instinct, nothing more, that the threat or fear of radical healthcare reform somehow can affects provider behavior. How it does that, or how I could ever show that, I have no idea, but it's an instinct that I just put out there, or at least a startling, fact to observe of when we've seen that slow down.
Is this recent phenomenon a US phenomenon, or is it a global phenomenon? That if you look at other advanced countries, do you see a similar decline in healthcare expenditures?
I do not believe so, but that is a good question. I don't believe so.
So what do you expect with new technology in terms of artificial intelligence, that we can actually sift through databases, have much better analysis and outsourcing? Can I make you speculate a little bit in that direction with AI?
In terms of health insurance?
Or health expenditures, new technologies bringing costs down. I mean, there are 2 ways you can bring the costs down. You can also make it more and more refined.
So there's a lot of really interesting work in this. My colleagues at MIT, Nikhil Agarwal and Tobias Saltz, have a really nice recent paper where they do a sort of randomized experiment of giving AI assistance to radiologists reading scans, and the answer is, it's, as with everything, it's complicated. There are ways in which AI can complement physicians. There are ways in which they can substitute. It depends how physicians, update in response to the signal they get from the AI. So I think it's an incredibly important and exciting line of work. I don't think we know the answer yet. I'd say something that I would really like to see more of that I think is a potential source of efficiency is that, healthcare has traditionally been very spatially differentiated, like you could only get it near your house. And now, both with the growth of telemedicine, but even for decades, in principle, a radiologist in another country, in a low-income country, could be reading your scans. I think that's another way that one could be more efficient that, needless to say, the AMA is not a supporter of. But I think there are real scopes for learning more about what we can do to improve efficiency.
So let me conclude with one question, which is, your main thesis is that essentially we provide insurance already in an implicit social contract way, and why don't we make it explicit? Because we as human beings care about others' well-being. Would you say the same should apply for homeless people? We should provide shelter, universal coverage of shelter, a minimum amount of shelter. It's just extending it to other areas. And why don't we care for the homeless as much as we care for the sick? Or is there a difference in social?
That's a really good question. It's something I struggled with a lot in working on this book. There were moments when, you're thinking about the social contracts and you're like, why just health? Why not food or housing or education? And we talk about this in the book that, philosophers have pondered this more than we have, and we summarize their views. But I think ultimately where I came down is these are completely additively separable in the sense of whether or not you believe that we have a social contract to provide food and housing and education to people, we're going to need the universal basic coverage. And I go back to the Charles Murray, point, which is suppose we instead provided, universal food, housing, education, and a universal basic income for discretionary spending, and people chose to spend it not on health insurance, we would end up back in this same position. So I think it's a yes and or a yes but. If you think the social contract is limited to health, we can stop here. If you think it extends to other things, we need additional programs, but they won't ever be a substitute for a universal basic health insurance system.
Thanks a lot, Amy. It was really nice to have you and present your ideas about the book, and I hope politicians will pick it up and make it reality.
I hope so too. Thank you very much for having us.
Great, thanks. And thanks to all of you for participating, and I wish you happy holidays, and we'll see you next year again, 2024. Bye-bye, everybody.